After completing the primary assessment, we move into the secondary assessment. This is a systematic physical examination of the patient, which may be performed at the scene, in the ambulance, or not at all if the patient's condition does not require it. The purpose is to identify hidden injuries or conditions that may not have been immediately apparent. The secondary assessment includes inspection, looking at the patient for abnormalities, palpation, feeling for abnormalities, and auscultation, listening to the body with a stethoscope. One way to ensure a thorough secondary assessment is by using the mnemonic DCAP-BTLS. This stands for deformities, contusions, abrasions, punctures/penetrations, burns, tenderness, lacerations, swelling. Compare findings on both sides of the body, when possible, to identify asymmetries or abnormalities. The extent of the secondary assessment depends on the patient's condition. In trauma patients, a head-to-toe approach may be necessary to locate hidden injuries. In medical patients, the assessment is often focused on the primary complaint. Be systematic and avoid missing any critical signs. Keep in mind that the goal of the secondary assessment is to uncover any injuries or conditions that were not obvious during the primary assessment. If a rapid primary assessment was performed due to a critical condition, this step helps refine and confirm the findings. In cases where the patient has a non-significant mechanism of injury or a known medical condition, a focused assessment is more appropriate. This involves concentrating on the body part or system that is affected by the chief complaint. For example, if the patient complains of chest pain, focus on the cardiovascular and respiratory systems rather than performing a full-body assessment. When assessing the respiratory system, expose the patient's chest to look for any visible signs of airway obstruction or respiratory distress. Observe for symmetry in chest rise and fall, listen for abnormal breath sounds, and measure the patient's respiratory rate. Normal respiratory rates in adults range from 12 to 20 breaths per minute, while children breathe at a faster rate. Count the number of breaths over 30 seconds and multiply by 2. If the rate is too slow or too fast, the patient may need oxygen or ventilatory support. Assess the rhythm of breathing. A regular respiratory pattern means that the time between each breath is consistent. An irregular pattern may indicate neurological or respiratory issues. Pay close attention to the quality of breathing. Normal breathing should be silent and effortless. The presence of wheezing, stridor, or crackles may indicate airway obstruction, fluid in the lungs, or other respiratory issues. Depth of breathing is another important factor. Shallow respirations may indicate inadequate ventilation, while deep, labored breathing could signal respiratory distress. Listen for breath sounds at the front and back of the chest. Proper auscultation involves listening to the chest in multiple lung fields. This allows for the identification of localized or widespread breathing abnormalities. When listening to breath sounds, recognize normal and abnormal patterns. Wheezing, crackles, rhonchi, and stridor each provide clues about the underlying respiratory condition. The cardiovascular assessment includes checking for trauma to the chest, listening for heart sounds, and evaluating the patient's pulse, respiratory rate, and blood pressure. Pay attention to any signs of poor circulation. When assessing circulation, look at the skin. Is it pale, cyanotic, or flushed? Compare distal pulses on both sides of the body, and listen for abnormal heart sounds that could indicate cardiac complications. A normal resting pulse rate for an adult ranges between 60 and 100 beats per minute. Younger patients tend to have faster pulses. If the pulse is too slow or too fast, consider potential cardiac issues. Assess the quality of the pulse. A strong, bounding pulse may indicate high blood pressure, while a weak, thready pulse may suggest shock or poor perfusion. Evaluate the pulse rhythm. A regular rhythm indicates that heartbeats are evenly spaced. An irregular rhythm could indicate an arrhythmia, which may require further medical intervention. Blood pressure is the force exerted by circulating blood on arterial walls. Low blood pressure could indicate shock, dehydration, or blood loss, while high blood pressure may suggest hypertension or other cardiovascular conditions. Low blood pressure is a late sign of shock and must be taken seriously. If the blood pressure is dangerously high, the risk of strokes, heart attacks, or arterial ruptures increases. When taking blood pressure manually, ensure proper cuff placement. The lower border of the cuff should sit about an inch above the antecubital space. Blood pressure can be measured using auscultation or palpation. The auscultation method involves listening for Korsakoff sounds, while palpation is useful when no stethoscope is available. Recognizing normal, high, or low blood pressure is crucial for patient care. Hypotension requires immediate treatment, while hypertension may indicate an underlying condition needing further evaluation. Neurological assessments should be performed on patients with altered mental status, possible head injuries, or signs of dizziness or syncope. Use the AVPU scale and assess for any focal neurological deficits. In addition to AVPU, the Glasgow Coma Scale (GCS) can be used for more detailed neurological evaluation. This assesses eye-opening, verbal response, and motor function to determine the patient's level of consciousness. The pupils are the black, central portions of the eye, and they play a crucial role in assessing neurological function. Normally, pupils should be round, equal in size, and responsive to changes in light. The absence of any light causes pupils to dilate, while exposure to bright light should cause them to constrict. Abnormal pupil findings can indicate serious medical conditions. Dilated, fixed, or unequal pupils may signal brain injury, stroke, or drug use. For example, one dilated pupil with the other constricted could indicate increased intracranial pressure. Always compare both eyes for any differences. There are several potential causes of abnormal pupil reactions. These include head trauma, stroke, brain tumors, inadequate oxygenation or perfusion, and drug or toxin exposure. If a patient presents with abnormal pupils, further neurological assessment is necessary. Use the PEARRL mnemonic to assess pupil function. Pupils: equal and round, regular in size, light reactive. If a patient's pupils do not meet these criteria, it may indicate an underlying neurological issue that requires further evaluation. When assessing neurovascular status, we evaluate the patient's sensory and motor function. This is essential for detecting nerve or circulation issues, especially in trauma patients. Start with motor assessment. Check for bilateral muscle strength by having the patient squeeze your fingers or push against resistance with their feet. Weakness on one side could indicate a stroke or spinal injury. Next, assess sensation. Ask if the patient can feel light touch or pain in their extremities. Compare distal and proximal responses to detect nerve damage. Finally, check circulatory status by assessing pulses in all extremities. If pulses are weak or absent, there could be a serious vascular issue. If you detect deficits, document your findings and communicate them to the receiving facility. When assessing the head, neck, and cervical spine, we are looking for signs of trauma, swelling, or neurological impairment. Start with the scalp and skull. Gently palpate for deformities, swelling, or tenderness. Open or depressed skull fractures may indicate a severe head injury. Next, examine the patient's eyes. Check for pupil size, equality, and reactivity to light. Also, look at the sclera. A yellow tint could suggest liver disease, while bloodshot eyes might indicate trauma or substance use. Check the ears and nose for fluid leakage. Clear or pink-tinged fluid may indicate cerebrospinal fluid (CSF) leakage, a possible sign of a skull fracture. Assess the jaw and mouth. Look for broken or missing teeth, which could become airway obstructions. Also, note any unusual odors. A fruity smell may indicate diabetic ketoacidosis, while alcohol or chemical odors could suggest poisoning. Finally, palpate the cervical spine for any tenderness, step-offs, or deformities. If there is any concern for spinal injury, immediately immobilize the patient to prevent further harm. Continuing with the head, neck, and cervical spine, always assume a cervical spine injury in trauma patients until proven otherwise. If the patient has neck pain, tenderness, or altered sensation in the extremities, apply spinal precautions. Use a cervical collar if needed and limit unnecessary movement. For facial trauma, assess for asymmetry, swelling, bruising, or fractures that could compromise the airway. Be especially cautious of jaw instability and trismus, lockjaw, which may indicate a serious injury. Now let's move on to the chest assessment. Start by inspecting the chest. Look for deformities, bruising, open wounds, or paradoxical movement. A flail chest, where a section moves opposite to normal breathing, is a serious sign of trauma. Next, palpate for tenderness or instability. Feel along the ribs and sternum for fractures. Auscultate breath sounds at multiple locations, front and back. Absent or diminished lung sounds could indicate a pneumothorax, while wheezing, crackles, or rhonchi may suggest other respiratory issues. When assessing the abdomen, divide it into 4 quadrants. RUQ, liver, gallbladder. LUQ, stomach, spleen. RLQ, appendix. LOQ, intestines. Palpate gently to check for rigidity, tenderness, or guarding. Pain in a specific quadrant can help identify underlying issues. Rebound tenderness may indicate peritonitis. A pulsating mass suggests a possible abdominal aortic aneurysm, AAA. Distension and absent bowel sounds could signal an obstruction. For female patients, always consider pregnancy-related emergencies when assessing lower abdominal pain. Moving on to the pelvis, check for instability, pain, or deformities. If you suspect a pelvic fracture, do not palpate aggressively, as it could worsen internal bleeding. Inspect the extremities for swelling, deformities, or lacerations, loss of sensation or movement, absent or weak distal pulses. If the patient cannot move an extremity or has severe pain, consider fracture, dislocation, or nerve injury. Splint injuries as needed. To examine the posterior body, carefully log roll the patient while maintaining spinal precautions. Look for spinal tenderness or deformities, penetrating injuries or bruising, exit wounds if the patient has gunshot trauma. Always check the spine for step-offs or tenderness, which could indicate a vertebral injury. While physical assessments are key, we can use monitoring devices to gather additional information. Pulse oximetry measures oxygen saturation. Values below 94% may require oxygen therapy. Capnography evaluates ventilation and perfusion. Abnormal values could indicate respiratory failure or shock. Blood glucometry checks glucose levels. This is essential for patients with altered mental status to rule out hypoglycemia or diabetes-related issues. Remember, these tools do not replace a thorough physical exam. They complement your findings. Pulse oximeters measure oxygen saturation in hemoglobin and are useful for identifying hypoxia. Normal SpO₂, 94 to 99%. Hypoxia, less than 94%. Critical hypoxia, less than 85%. However, low perfusion, cold extremities, or carbon monoxide poisoning can interfere with readings, so always correlate SpO₂ with your full assessment. Capnography measures exhaled carbon dioxide, EtCO₂, and helps assess respiratory function, perfusion, and metabolism. Normal EtCO₂, 35 to 45 millimeters of mercury. High levels suggest respiratory failure or poor perfusion. Low levels may indicate hyperventilation or cardiac arrest. Blood glucometry checks glucose levels. Normal fasting glucose is 70 to 110 mg/dl. Abnormal values can indicate diabetes-related emergencies. A sphygmomanometer is used to measure blood pressure. Normal BP, 120 over 80 mmHg. Hypotension, less than 90/60th millimeter of mercury, may indicate shock. Hypertension, 140/90 mmHg, can lead to strokes or cardiac events. Check both arms if one reading seems abnormal, and avoid using a BP cuff on arms with AV fistulas, mastectomy sites, or injuries. Reassessment is a continuous process that ensures we are staying ahead of any changes in the patient's condition. Start by repeating the primary assessment. Recheck airway, breathing, and circulation to ensure there are no new or worsening life threats. Monitor vital signs every 5 minutes for unstable patients and 15 minutes for stable patients. Reevaluate the chief complaint. Has it changed? Has the pain worsened or improved? Reassessment allows us to track trends and respond quickly to deterioration. As the situation evolves, we must be ready to adjust our treatment plan. Ask yourself, is the current treatment effective? Are interventions like oxygen or bleeding control working? Has an identified problem worsened? Is the patient's breathing becoming more labored? Are new symptoms developing? For example, a patient with chest pain might now be short of breath, signaling worsening cardiac distress. If significant changes occur, prioritize rapid transport and prepare hospital teams for an urgent handoff. During transport or continued care, always double-check all interventions. Is the airway still open and protected? Is the patient oxygenating properly with SpO₂ in the normal range? Is bleeding controlled? Or is the bandage becoming saturated? Are 4 lines, splints, or dressings secure and effective? If an intervention fails or needs adjustment, make corrections immediately and document any changes. Proper documentation and clear communication are critical in patient care. Record all reassessment findings, including trends in vital signs, pain levels, or new symptoms. Note any treatments provided and how the patient responded. Communicate updates to hospital staff so they have a full picture of the patient's condition before arrival. A well-documented reassessment ensures continuity of care and can improve patient outcomes. Stay alert, reassess frequently, and always be ready to adapt.